Good morning and welcome to yet another very short presentation. I came to know students had given feedback that there was one question about IV fluids. The composition of IV fluids was given and you were asked to identify the IV fluid. Now I do understand the question was quite straightforward, for which you had to mug up the composition. Now, what I wanted to do in this presentation is take you through the basics so that you no longer have to mug up the compositions. If you have to mug up the compositions and remember the name, it is not the way that you'll be able to handle clinical problems, because your next is going to have clinically based questions very much, or even the next NEET. So I thought I'll build up on concepts and then you will have some clarity naturally. We will take these concepts to very generic situations. Like say a patient comes with a hypovolemic shock due to blood loss. We will see what IV fluids will suit him best. Then further building on this, we will come to specific case-based common scenarios, like a 70-year-old man sustained burns. So you have the age factoring in. So it is almost a personal way of looking at the problem. It is no more generic. And then you also told that, and then it's also mentioned that it is burns. So you can be slowly building up on these concepts, because your questions need not necessarily be recall questions. They will be very clinically layered, and you need to read in between the lines in the STEM for you to choose the right option. Here's the first question. An IV bottle was probably shown or just the constituents. Now I purposely put on a bottle from my personal collection so that the students can relate to the clinical part. Every day you will be handling IV fluids. Minimum at least 5 times you'll touch the bottle in your days in the ward. And this has been just put here, the constituents have been put here so that you know the ingredients are clear or the components are clear. Whereas here you have to read through the plastic cover and you have to read. So I made it a little more the same thing, just cut and put. Now the idea is not to have shortcuts in finding out what is your IV fluid. You know for what a particular IV fluid is used and why, automatically you will be able to you'll be able to give the right option and zero in on your correct answers. But for that, you must know basics of fluid management. And the most basic of fluid management is knowing about your intracellular compartment, the extracellular compartment, and which is the interstitial compartment and the vascular compartment. So you have 3 compartments and 2 broad compartments and 3 individual components. If you know this part, it's much easier for you to understand IV fluids. So that is the building template for you to understand IV fluids. Let's have a look. Now I can show this diagram and you will be forced to imagine. What is ECF? What is ICF? What are these two? No need. Don't break your head too much. When you're reading about IV fluids, keep both the diagrams. One, this will give you the exact mathematics. This will give you the exact pictorial part. It will be much easier for you to remember. Just remembering compartments, you cannot imagine the fluid moving in and out. But when you also remember this diagram, it's a very simple diagram. You will be able to understand fluids more precisely. So as I told you, the intracellular fluid, see the cells sitting here, there are billions and trillions of cells. They all have water. They have up to 66% of the water in the body is here. Now let's come to the extracellular, that is the interstitial. See, interstitial, in between the cells. You have 23% sitting there and the remaining is 11%, which is in your vascular compartment. Simple. But if you really look at it, this 11% is what contributing to perfusion. The blood pressures, the perfusion, the amount of oxygen carried to the vital organs. Everything in the body is a vital organ. Only thing is there is a priority with immediate continuation of life. Like your heart, brains and kidney. The next thing will be your liver, pancreas, etc. Then you have your skin, muscle, bones, everything. So keep this in mind. This 11% is the one which is going to perfuse the vital organs. If you remember this part, you will not get confused. So why are we concentrating that the load here should be okay, so that pressure is okay, so that venous return to the heart is okay? It is all interlinked, so that enough blood goes to the brains, enough blood goes to the heart, and enough blood goes to the kidneys. Fine. So we are only looking at this 5 liters. How can I make sure that I build up this 5 liters and maintain the 5 liters in the intravascular compartment? So everything else will disappear. But for it to disappear, you must know how much water they are holding. If you know that, you will start concentrating here now, because this is already stored in your brain. So now, how can you fill up? Either there is loss of blood or plasma or plain water. You can fill it up with two things, either colloids or crystalloids. Simple, you can fill this compartment. Now let's see what are crystalloids, why, how long they will be there, other things. Very simple diagrams. Have a look. This is a semi-permeable membrane. As usual, all cells, all organs will have semi-permeable membranes only, because they need to take things and give out things. So this semi-permeable membrane, let's have a look. You put crystalloids into the vascular compartment. They are so small, they will move out easily into the interstitial space. But if you put colloids, they are very huge. I'm not going to go into the exact measurement of the crystalloid molecule and exact measurement of the colloid molecule. We'll come to it later when we start building on the IV fluids. But look at colloids. They are so large. Only 25% will manage to come out. Here 75% will go. So 70% of what you gave is still here. It's not only question of still here, it's also a question of how much went in and lodged here. So here you have only 25%, but 75% went off into the extracellular space. And this is what will cause edema, your pulmonary edema, or your bowel wall edema, or fluid accumulating in the peritoneal cavity. So it's not only very less to push the perfusion, it is also quite a bit sitting inside the parenchyma. You don't want that. So here quite a bit is sitting inside pushing the perfusion, and very little is going into the extravascular space or the interstitial space, which is a component of the extravascular space, and cause havoc. So it is doing its job here and causing less havoc, whereas this is hardly anything is there to do the job, but it is causing enough havoc there. Now you might ask, when there is so much of difference between these two, why alone this is being used? What I want to tell, there are advantages of using is, one is cost factor. Number two, it will be readily available. And number three, not all patients will need this straight away. So you start off with this. There are some patients, some clinical scenario, which will settle down. That 25% remaining is okay for them. They will settle down. And this 25-75 doesn't happen the moment the molecule goes into the vascular compartment. It will take 1 to 2 hours to seep out. Within that time, you'll have enough homeostasis happening in the body to make sure that it has handled this problem with just 25% in the vascular space. So keep this in mind. It's a little easy to understand. Now, large volume you have to give. So it will produce edema, but it is cheap because it is 10 times less. Now this NaCl, which is part of your crystalloids, will produce acidosis. So you can use, and you decided to use a crystalloid. With NaCl, there is a problem. Use an alternative crystalloid. All this I'll be taking later in the presentations, different presentations. So you use crystalloids only, but you use an alternative for the problem that sodium chloride will not give. Fine. What about colloids? Better intravascular expansion, we know it. It is 10 times more. Cannot give in sepsis and ARF. I will again come to colloids in a separate discussion. Unless I build up your basics with layer by layer, difficult for me to just throw information about colloid. You will start learning by hearting. That is not going to help you in the NEET exam as well as in the long run. Now, forget it. Where are we? This colloid and crystalloid debate will keep going on. If you understand it's an ongoing process, you will not unnecessarily muddle your head with controversies, with deliberations, with debates. As an undergraduate, for this particular position, you'll know what IV fluids to use, at least as far as the answers are concerned. Fine. Fluid guidelines will be generic. So, across situations, example in the advanced trauma life support, you start resuscitation with ringalactate. Advanced trauma life support does not tell you cannot use colloids. So, you start off with ringalactate because you know a patient needing resuscitation who is in shock and trauma needs resuscitation, he will need minimum 2000 ml of crystalloids. And that crystalloids, you cannot give a normal saline because acidosis chances are much more. Now, I'll tell you why normal saline has acidosis and ringalactate does not have acidosis later on when I make the other presentations. So, this is the composition of crystalloids and colloids. Just have a look. This is your ringalactate. The sodium is quite less. No, the thing is, when you look at IV fluid composition, first decide whether it's colloid or crystalloid. That is very, very important. You must decide whether it is colloid or crystalloid. Now, if you see these, the components will be there. You know straight away they are colloids. So, in your options, you will try to pick up colloids. So, first thing is go and look at this. If you find any of these colloids, then you know your option should be a colloid. If you don't find these, you know it's a crystalloid. This is how you can narrow down and come. So you got rid of this whole group and you went here. If you find a solution having too many electrolytes, too many things, it is a Hartmann's. Especially when you find lactate, 100% it has to be Hartmann solution or ringalactate. And if you find potassium and calcium, all the more you narrowed it down. Whereas your dextrose will also have some amount of potassium. So any IV fluids, look whether it's colloid or crystalloid. If you know that there is no colloid, straight away you will jump into this group, simple group. There you go and see for potassium, calcium and lactate. Too many components belongs to ringalactate. Also potassium, think twice. It could be this or this. You will know from the sodium ions. This is very important. Fine. So this is how you look at an ingredients of an IV fluid and decide what IV fluid it is. Next time I will take you into what are the characteristics of sodium chloride, what are the disadvantages, what clinical scenarios you give. The next one is the ringalactate and also a little bit about the dextrose. And the colloids I will be talking about as a big group. Maybe little bit differences because some colloid will have more advantage or more because they have an advantage they'll be used in certain situations. But first of all you must know what is intravascular, intracellular and your interstitial space. How much of water is there everywhere. How intravascular volume, which is only 11% of body water, is needed for perfusion of vital organs. And number 3, when you give colloids, how long do they stay? When you give crystalloids, how long do they stay? And their problems. We'll come to it again later. You must remember that this debate will go on, and most of the time the recommendations are very generic, not individualized. That is why debates are coming up. The very fact there are debates, it is not individualized. So keep this in mind, and we'll take you through a little more deeper into the IV fluid. Now have a look. This is a crystalloid you're giving. The holes are so small, big, that it readily filters out. The same thing which I showed you. You can't be going on filling this. Ultimately, you're filling this only. What you want is some filling to be here. This is here. Similarly, in a colloid, you see enough filling happens. It will bring up the pressure. It will bring down the interstitial edema. This diagram is the basis of fluid management. Then only the rest will build up. Then you will decide crystalloids are better than colloids, colloids are better than crystalloids, crystalloids have these disadvantages, colloids have these disadvantages. So I thank you all for staying with me in this presentation. There's nothing much to show clinical images. We are talking about IV fluids, we are talking about the cellular level and the tissue level. Difficult for me to match with the clinical imaging. But once we finish this topic on fluid replacement, I should be able to bring clinical images from my personal collection to lighten up or to bring things forward with the clinical scenario. Now you will be able to look at the clinical scenario, analyze what exactly has gone wrong, find out the solutions and give the right options. So again, thank you very much for being with me, and please do subscribe to my channels.